the laparoscopic and robotic repair for inguinal hernia is essentially the mini invasive technique to repair the inguinal hernia. So nowadays, I think is the preferred, the best technique to repair this type of hernia because of the benefit, specifically the quicker recovery, less chronic nerve pain, and less risk of recurrence after hernia repair. So the open is still a very much a valid option. There are some specific indications, and these might be more related to the type of patient, and because of course in open there are possibility to do the operation under spinal anesthesia and or even under local anesthesia with a regional block rather than a general anesthetic. So these are much more suitable for patient who has a high risk for general anesthetic. But essentially in one word, the laparoscopic and robotic repair are the mini invasive technique done with a keyhole approach. Sorry, in my practice, my default position is that every patient should have the repair of an inguinal hernia, especially if it is a recurrent, or especially if it is a bilateral, done laparoscopically or robotically, due to the well-established benefit of this approach. There is less pain post-operatively, therefore a quicker recovery after surgery, a faster return to activity, including sport activity, generally after 6 weeks. There is a less risk of chronic nerve pain post-operatively and less risk of recurrence of the hernia. So these are quite established benefits of this mini-invasive approach. But of course, there are some specific requirements. So for example, patient who had multiple intra-abdominal surgery, or even sometimes a very contaminated surgery, for example, a perforated appendicitis or complicated bowel resection, then in that case we are expecting a higher risk of intra-abdominal adhesions, which might be involved in the bowel, and therefore the risk of intra-abdominal injury during the laparoscopic or robotic repair can be too high, and therefore in that case the discussion will be probably to go for an open approach. The other indication would be a patient who has a high risk for a general anesthetic, for example, for cardiac reason or respiratory reason or poor exercise tolerance. Anyway, there is a high general anesthetic risk for one reason or the other. In that case, we can consider the open approach a very much valid approach, because this can be done with a regional block like, for example, a spinal anesthesia. So spinal anesthesia with sedation. The patient is very comfortable during the operation, and the approach is done in open, working at the level of the abdominal wall. Very briefly, the main advantage of open repair is the fact that we can avoid the general anesthesia. So the patient can be operated with a spinal block and sedation. So there is an injection through the spine to numb below the waist, and then a little bit of sedation to keep the patient comfortable throughout the operation. This is the main benefit. Open repair is also indicated, or if you want to consider as a very valid option when we're dealing with giant inguinal scrotal hernia. I hope that we don't get too many patients at this stage where they're waiting the wait is so long that the hernia has dropped entirely in the scrotum. And sometimes in that case, laparoscopically can be very difficult to reduce the hernia from the scrotum, from the inside the abdominal cavity. In that case, it's probably better an open approach. And so essentially, in 2 words, open surgery is for the high-risk patient who doesn't want or cannot take the general anesthetic, or the patient who has a giant inguinal scrotal hernia. These are the main, in my practice, these are the main indications to consider open surgery. The other time when we consider open surgery is if the patient has already had failed laparoscopic or robotic repair, in which case that territory has been compromised already. I cannot do the dissection again inside the abdomen. I need to go from outside. These are the three main indication advantage of the open repair. Otherwise, everything else, all the advantages are in favor of the laparoscopic and now these days of the robotic approach. Essentially, the two techniques are very similar. The main difference is with the robotic arm, we can have the surgeons can achieve a better quality in the imaging, so there is more precision during the dissection. So typically with the robotic, the spillage of blood is very, very minimal. There is some indication that because there is less spillage of blood, there is less inflammatory response, which should translate in less pain post-operatively. In practice, it is very difficult to feel the difference between a laparoscopic and robotic hernia because they're both quite with a quick recovery with low pain post-operatively. But the principle is that robotically, the precision of the surgical dissection is much higher because there is a better resolution. As I said, the main advantage of these two techniques is that we repair the hernia from the inside, so we can create a large space, a large pocket where we can put a wider mesh, and we don't need to suture anything laparoscopically. We just need to suture the peritoneum to close the pocket, and we just need to secure the mesh one way or the other. In my practice, I tend to use most of the time glue to avoid the pain of the fixation of the mesh. But the beauty of these two techniques, laparoscopically or robotically, is that the hernia is the mesh to repair the hernia is in a very safe position. Is away from the skin where the nerves are and away from the bowel because there is a peritoneum covering the mesh completely. These are the main benefits. So reducing the pain, reducing the risk of chronic nerve pain, and because of wider dissection with a wider mesh, less risk of recurrence. The disadvantages are the one that I already discussed. As I said, laparoscopically or robotically, we're working inside of the abdominal cavity. So during the consultation, I will explain this to clarify that. Is implicit that because we're working inside the abdomen, we have to discuss the remote possibility of bowel injury. That's the main difference. But as I said, during my consultation, I will explain that normally as soon as position the first port, the umbilical port, if I will assess how big is the hernia and what's the situation with the bowel, how many adhesions between the bowel and the abdominal wall. If the risk is too high, there will be a clear indication to convert to open. So that's why, as I said earlier, if there is a patient with a past medical history of complex bowel surgery, especially if it's done in open or a contaminated surgery, like for example perforated appendicitis, there could be an indication to consider going straight to open. On the other hand, the disadvantage of the open technique is that there is a scar, of course, in the groin. It probably is not the biggest issue, but at the end, it's definitely less than 10 centimeters. But there is a lot of dissection at the level of the abdominal wall. So we need to dissect it through the muscle, go inside the inguinal canal. So we need to disturb the nerve. That sometimes it needs to be destroyed to prevent chronic nerve pain. So there is a more inflammatory response. Therefore, typically after open repair, you will get this swelling in the groin, a little bit of uncomfortable discomfort, and sometimes, unfortunately, some pain, which lasts for first a couple of weeks. It depends on mainly on the patient. So the general anesthetic risk. It depends on the type of hernia. So how big is the hernia, for example, and if it is a recurrent hernia and how it was repaired before. These are the main factor to take in consideration when deciding the best approach. My advice is to always have all options available, open, laparoscopically, robotically. So that's in my practice, I'm able to offer all the 3 options. And I will strongly advise against going to someone who doesn't have the one approach or the other, because there will be a bias, of course. So it's always better to have all the 3 options available, and then you can decide. But the important thing, at least, is to have, unfortunately, even for me, the robotic approach is based on the hospital, because, of course, if there is no robot, unfortunately, we cannot do the robotic approach. But we can always discuss this as an option, because I'm sure that in the next 10 years, from the laparoscopic repair, we will move to the robotic repair.